Welcome to today's National Library of Medicine History Talk, being held virtually thanks to the outstanding staff of our institution, the National Library of Medicine, as well as NIH Videocasting, and we thank our colleagues there very much. My name is Jeff Resnick. I'm Chief of the Library's History of Medicine Division, and it's my privilege to welcome all who are watching remotely via our global live stream and everyone who's following along on Twitter using the hashtag NLMHistTalk. NLM's History Talks are designed to promote awareness and use of NLM and related historical collections for research, education, and public service in biomedicine, the social sciences, and the humanities. The series also supports the commitment of the National Library of Medicine to recognize the diversity of its own collections, which span 10 centuries, encompass a range of digital and physical formats, and originate from nearly every part of the world. And the series is also intended to recognize the diversity of individuals who use these collections to advance their research, their teaching, and their learning. Thanks again to everyone for tuning in. And with this brief introduction, I'm going to turn things over to Dr. Patricia Flatley Brennan, Director of the National Library of Medicine, who's going to introduce today's speaker, Dr. Cynthia Connolly. Dr. Brennan, over to you.
Thanks very much, Jeff. Good afternoon, and welcome to those of you who are joining us for this lecture today or virtually in the future. It is a particular treasure at the National Library of Medicine to have such a rich collection of historical materials, and we welcome the attention of scholars to explore these materials, discover their past stories, and bring them into their present impact. We're privileged today to have one of our fellow scholars, Cynthia Connolly from the University of Pennsylvania, to present this lecture. Dr. Connolly is the Rosemary B. Greco Endowed Term Chair for Advocacy and Professor of Nursing at the University of Pennsylvania School of Nursing. She has several other titles. She's Associate Director for the Barbara Bates Center for the Study of History of Nursing, well known across the country for its impact on history and nursing. She's also co-director for the field, she's co-faculty director of the Field Center for Children's Policy, Practice and Research, and she's a senior fellow in the Leonard Davis Institute for Health Economics. This background brings together Dr. Connolly's understanding and experience as a pediatric nurse and nurse practitioner, and her history, her thoughts, use of history as a scholarly approach, and her passionate interest in history. She first began trying to understand children from the lens of history, the perspective that led to making policies that were supportive of and shaping children's health care. Her perspectives are deeply grounded in social justice. She actually spent time as a fellow in the United States Senate, and she's had many years of pediatric nursing practice brought together with this study of history, policy, and policy education. The research that she's undertaking, though, has tried to understand how ideas about children, particularly what their best interests are, shapes what we do and don't do through policy, legislative, and regulatory approaches for reform. Now, we face this right now immediately when we look through the COVID epidemic and try to understand both the experience of children who have been infected with the coronavirus and the proper treatment of those children. NIH has a particular interest in the lifespan approach, and we now require our grantees to explain specifically their policies for inclusion across the lifespan in clinical trials and observational trials. So Dr. Connolly's work has particular relevance for us right now. She also, though, uses her love and lens of history to understand the intellectual ideas that shape the practice of nursing and the way we've engaged with patients in the past. She has written several books. She joins us today, though, specifically to talk about material from her books, Children and Drugs, Drug Safety, Balancing Risk and Protection in 20th Century America, which was funded through the Robert Wood Johnson Foundation Award and the National Endowment for the Humanities, published about 2 years ago by Rutgers Press. This work traces the history and use and marketing of drugs in children in the 20th century and a history that sits at the intersection of state, business, and historical, clinical interest, parents' interest, and providers' interest. Children and Drug Safety eliminates the historical dimensions of clinical policy issue with great contemporary significance. As we've said before, the importance of understanding the experience of children, their exposure to drugs, and their response is really quite critical. At times, this concept of the best interest of children has actually kept them out of studies. Recently, there's been a swing in the pendulum to engaging children in studies, and the studies those decisions have to be based on considerations of society's obligations to children, their understanding of the place of children, and the responsibility of protection. We also raise an issue in the study of children of who has the right to consent or ask them to participate in studies, and how the funding organizations, including our own NIH, should be addressing this very complex intersection here. Dr. Connolly has been a participant in the National Library of Medicine's intellectual activities for many years. She received what we refer to as a G13 grant for scholarly work, an unusual opportunity for a scholar to develop a book-long manuscript. And Dr. Connolly's work explored the experience of children with tuberculosis in the focus on the period from 1909 to 1970, looking at the tuberculosis preventorium, the strategies that we use to protect, and the strategies and the opportunities we missed in protecting children. Recently, Dr. Connolly continues to look at programmatic level interventions with children. Her work, though, has expanded to include the study of nurses, filling in a gap in the historiography of nursing. Nurses have been deeply involved in human experimentation in many different ways. We know extremes on both ends, and we're looking forward to Dr. Connolly's work bringing in an understanding of new actors in a different lens to explore both the social and the professional networks in which knowledge is built. I want to welcome again Cynthia Connolly. She's a friend of a friend, and we've met once before. I'm looking forward to her presentation today. Dr. Connolly, thank you for joining us at this time.
Thank you, Dr. Brennan, for that lovely introduction. And thank you, Dr. Resnick. And thank you to everyone for being here today. It's a beautiful fall day in Philadelphia. And so I feel like and I think it is up and down the East Coast. And so I think there's a lot of competition to be for this talk. So I really appreciate you being here. So I got interested in the history of children and drug policy in 2002 when I was doing a fellowship on Capitol Hill. At that point, I'd been a pediatric nurse for more than 20 years, and I had done a historical dissertation on children's health. And so I thought I knew something about pediatrics in the United States. So at a hearing for what became two landmark pieces of legislation, the Best Pharmaceuticals for Children Act and the Pediatric Research Equity Act, which together mandated safety and safety information in drugs used in the pediatric population, Senator Chris Dodd, next slide please, made the following comment. Next slide. Thank you. And he said only a fraction of drugs that were on the market had ever been tested for safety in children. It's a lot like playing Russian roulette with our kids. I was absolutely astonished. I wondered how in the world I'd missed this. I had given hundreds of different drugs at premier children's hospitals where I worked, using my pharmacy, pediatric manuals, the Lane Handbook, and the Pediatric Dosage Handbook. I'd also been a clinical pediatric nursing teacher for many years, making sure my students were socialized into the complicated ballet at the bedside between pediatrician, pharmacist, and pediatric nurse to assure correct dosing and medication administration. And when I took this information to my pediatrician colleagues, most of them didn't know it either. I really needed to find subspecialists in pharmacology who told me, yes, that was absolutely correct. So here's what I did know, that problems in children had often driven major drug-related legislation in the 20th century. To cite just a few examples, the FDA was created in 1906 in part because of children's deaths, particularly infant deaths, from over-the-counter narcotics marketed as what were called then soothing syrups, didn't disclose that they contained opiates. Subsequent laws in 1938 and 1962 were enacted in the wake of disasters that involved a large number of children, and the legislative hearings were heavily suffused with child protection rhetoric. So how was it then, I wondered, that things had not gotten better for children? I thought it was the perfect example of a research question that engaged the pediatric nurse part of my brain with that of the historian part of my brain. Next slide, please. This paper is drawn from my 2008 book published by Rutgers Press, about the history of children and drugs, or therapeutic medicinal chemistry, in the United States in the 20th century. In the book, I try to chronologically and thematically trace pediatric drugs' political, legislative, and regulatory history using a series of cases. And just an FYI, except for where they intersect, I don't discuss immunizations because the biologicals have a different history and because there are already a number of excellent histories of vaccines. I was able to undertake a number of oral histories critical to this study and draw on primary archival sources from all over the country because of generous funding from a number of sources, but particularly because of a large grant from the Robert Wood Johnson Foundation, and then a grant from NEH, which gave me protected time to actually write the book. I'm happy to say more about source materials in the Q&A if anybody's interested in that. So this topic was of interest to me because it offered a window into more than just drug regulation and policy, although I was certainly interested in that. But it provided me with a unique lens through which to examine issues surrounding children's health without focusing on a singular disease, a professional group, or even a care site such as home or hospital. It also offered a rich template to study themes of children's risk, rights, and protection in the United States in the context of 20th century childhood, parenting, and healthcare delivery. And that it also sat at the interstate of these topics as well as the state and business made it especially interesting to me. So the second chapter of the book, the one I'm going to talk about here, is a pivotal one in my narrative. I chart the rise of the modern era of the sulfonamides and their use in children. I discuss how these drugs profoundly change the treatment of common and highly fatal pediatric conditions such as meningitis and pneumonia. And this is really where the meat of my book begins. Next slide, please. And I was able to do that because of a remarkable set of records and because of a remarkable set of colleagues at the NLM. My colleague, Janet Golden, had brought the existence of patient records from the Baltimore Infectious Disease Hospital, Sydenham, to my attention, and she and I subsequently drew on them for a paper published in the Bulletin of the History of Medicine. The chapter in my book uses much of the Sydenham data, uses much more of the Sydenham data and contextualizes it more broadly and deeply in the time stream of drug policy, child health, and clinical practice. And this is actually where you can find the finding aid for the Sydenham records. So the patient records were pivotal to what I wanted to capture because they afforded the opportunity to see the transformation of care on the ground as the sulfa drugs transformed infectious disease treatment for children. Every 10th patient record from Sydenham was saved and deposited at the NLM. I don't know how that decision was made to save every 10th versus every 20th, and I actually don't know how and why they ended up at the NLM. Perhaps if there's anyone from the History of Medicine Division on this call who does know that in the Q&A, they can educate us about that. I actually don't know. The NLM does require a formal application to see the records if they include patient records, which I applied for, and I also applied for and received expedited review from my own IRB at UPenn because of the rules in place governing the use of clinical records. Next slide, please. So let me get to my story. So in 1909, the Baltimore City Health Department opened the 100-bed Sydenham Infectious Disease Hospital. During its 40-year history, children comprised approximately 75 to 80% of patients at any given time. I examined hundreds of pediatric patient records from the 1920s until 1949, when the institution closed as an infectious disease hospital. It would open a few years later in 1953 as a hospital for Baltimore's indigent elderly. It closed at some point in the 1980s or 1990s, and the buildings were actually not torn down until 2013. The sulfonamide era at Sydenham was forged in 1935 with the hospital's new research alliance with the Johns Hopkins Medical School and the Harriet Lane Home, which is the pediatric service at Johns Hopkins Hospital. The institutional partnership created a new research and teaching mission at Sydenham and provided an infrastructure and funding for a laboratory to improve clinical care and also could stimulate research. So these changes not only permitted scientific findings to move quickly from bench to bedside, they brought a more rigorous flavor to hospital routines, and how that unfolded is one of the first things that became clear in the records. Before the partnership, for example, physicians hired by the health department who staffed Sydenham would jot a cursory medical diagnosis on the chart at admission. And that was often the only thing that was recorded until the child was discharged. But after 1935, the Hopkins pediatric house officers or doctors in training, supervised by Hopkins Medical School faculty, detailed the child's presenting symptoms, physical assessment, X-ray laboratory findings, differential diagnosis, a daily note, and then a discharge summary. In other words, they were using the conventional rubric in place at a large teaching hospital. And there's very little in the nursing records before the advent of the sulfonamide era. There's just very little by nurses in the charts. Next slide, please. Reports and publications from England in 1936 about a synthetic organic compound with antibacterial properties intrigued Sydenham physicians. They were especially interested because the then best available treatment for most infectious diseases, serum therapy, presented many challenges and only improved mortality rates marginally most of the time. The production of antibacterial serum therapy was also labor-intensive and expensive. First, the bacteria afflicting the ill person had to be identified in the laboratory. Next, a skilled technician needed to inoculate an animal with the bacteria. At Sydenham, it was typically a horse or a rabbit. Then harvest the resulting antibodies, which would then be injected into the person to help them fight the infection. Serum was highly perishable, often produced serious side effects, including fever, joint pain, rash, and even fatal allergic reactions. Everything about serum was more complicated in the pediatric patient. For example, the small blood vessels of very young children made the process more difficult and most likely more traumatic for them. By the 1930s, while commercially made, pure, more standardized sera was available, it was expensive, and a public hospital like Sydenham could not afford it, so they needed to continue to make their own. So there was real excitement at Sydenham about the sulfonamide's therapeutic potential. Almost immediately, doctors procured a small supply from several local companies, including the DuPont Chemical Company in Delaware, very close to Baltimore. They decided to try it on one of Sydenham children's most deadliest diseases, bacterial meningitis. The first child with meningitis to receive sulfonamide, one of the first sulfa drugs, for which there's a surviving record, was a white female toddler who arrived at Sydenham on December 4th, 1936, with a high fever, headache, and stiff neck, all suggestive of the condition. Laboratory tests confirmed streptococcal meningitis. The child first received serum with no response. Death was imminent until she received sulfonamide, at which point her doctors noted with amazement that she, quote, in her chart, showed rapid clinical improvement. And in more good news, not only could the drug be administered orally after initial injection, the more good news, it could be administered orally after an initial injection. The little girl returned home on Christmas Day, fully recovered, and that year's annual report describes her as the first person at Sydenham to ever survive streptococcal meningitis. It's important to note that until this time, the sulfonamides, pediatricians from elite medical schools and hospitals like Hopkins actually counseled against using drugs in the pediatric patient whenever possible. Most agents just weren't considered effective enough to justify their risk. Eminent Harvard pediatrician Charles Janeway later said that when he graduated from the Johns Hopkins Medical School in 1936, so right on the cusp of the sulfonamide era, there were only about 6 drugs a pediatrician ever needed to know. The sulfonamides changed that in dramatic fashion. And because 80% of Sydenham Hospital's patients were children, It was immediately clear that the institution provided a ready population of youngsters with bacterial infections who could, of course, hopefully be cured, but who could also be used to study the new drugs, how they were metabolized, excreted, and how to develop a dosing rubric for them. So a few words about who the children were. From the social histories and the records, it's clear that almost all were poor, of course, not unusual, of course, for a public hospital. Both Black and white youngsters received sulfonamides from the beginning. Physicians' notes and letters, however, document the normative racism in Baltimore in the 1930s. And you can really see this in their language about how often they judged the living conditions of families seeking help for their sick children. And by no means did Sydenham ever offer equal access to Black and white children. The historical record is clear. Between 1909 and 1924, no African Americans were admitted to Sydenham, despite the fact that infectious disease mortality, which was much higher in Black children than white in Baltimore, and Black adults as well as white adults in Baltimore. The institution maintained total racial exclusion until it moved into a new and larger location in 1934. At that point, the adult wards accepted African American patients, but were segregated by race. But the pediatric wards became integrated by race. But the census of Black children never rose above 30% in any year, despite their higher infectious disease mortality rates. Nonetheless, as best I can tell from the records, with regard to the early pediatric sulfonamide treatment at Sydenham, there's no evidence that race was used as a variable in determining who got the drug. Rather, physicians sought any child harboring the particular bacillus they were testing a specific sulfa drug on at that moment. While the sulfonamides dramatically changed the morbidity and mortality calculus for many bacterial infections, next slide please, they also revealed the limit of 1930s dosing schemata. Prominent pediatric texts had long lamented the weaknesses of age or proportion-based dosing schemes such as Young's rule that dated back to the early 19th century. And these were reprinted in pediatric medical texts even after World War II in the absence of any better rubric. They just continued to recommend them because they didn't feel like they had any way of thinking about drug calculation that was more meaningful. As they gained some experience with the sulfonamides, Sydenham doctors observed with surprise that toddlers sometimes needed a higher proportional dose to achieve the same therapeutic concentration of the drug in their blood than either an infant or an adult. These observations firmly challenged Young's rule and suggested that dosing requirements for some drugs were not linear according to children's size or age. This would have great clinical significance going forward. Pediatricians had long understood, dating back to the founding of pediatrics and founding pediatrician Abraham Jacobi in the 1860s and 1870s, who noted the ways in which children differed physiologically from children and adults. But the sulfonamides really revealed a sense of what this was going to mean in terms of dosing complexity using these new medications for children. Next slide, please. So a granular look at the patient records tells us something very different from an examination of reports in published reports in medical journals. The latter focus on the success or a failure of a new treatment. The former reveal the challenges of making them work on the ground and the many different decision points involved. In 1940, for example, a 19-month-old white baby boy was transferred to Sydenham from another Baltimore hospital for the bacterial infection pertussis, also known as whooping cough. On admission, doctors also diagnosed a secondary bacterial infection in his lung, pneumococcal pneumonia, and ear infection as well. They prescribed the latest new sulfa drug, sulfapyridine, and at the time of admission, his fever was over 105, and they characterized him as severely ill. What you can see in the record, and I've summarized it on this slide, is several weeks of his temperature rising and falling, starting and stopping the drug to try and figure out whether the fever is the result of a drug reaction, drug toxicity, the pertussis, the pneumonia, or yet another new infectious process. So he slowly got better, and on day 35, he was discharged, and his chart noted him as fully recovered. As best I can tell from looking at the publications coming out of Sydenham at this time, the case is noted in the medical literature as an instance of effective treatment for pneumonia with sulfapyridine in a patient aged 1 to 5 years. The patient records also show the personal responses of clinicians observing children recover from deadly infections. And this is my favorite part in the record, actually. The dry language that you see in a published medical report about the relative superiority of finding a new treatment contrasts vividly with the confusion, stops and starts seen in the record, and also the exuberance and emotion that a physician expresses that's rare in a clinical document, then or now. Red pens sometimes for results, exclamation points, words that rarely appear in a clinical record, such as startling, astonishing, or striking. So when the drugs worked. Rapid adoption of sulfa therapy for diseases like meningitis and pneumonia, and soon all bacterial infections, transformed the daily routines at Sydenham adopted during the serum era. While nurses had prepared serum for administration and assisted physicians in its once-a-day infusion, as I mentioned, the sulfa drugs could be taken orally, and in fact, it was their preferred route of administration. So getting the drug into children every 3 to 4 hours now became a nursing responsibility, as did administering the concomitant bicarbonate to prevent acidosis. For children too young or sick to swallow pills, nurses needed to problem solve ways of grinding the drugs up, mixing them with fluid or honey, usually, to get them to swallow the full dosage. If they refused some of the medication or vomited after its administration, nurses needed to assess how much the children had received and then try and administer the rest of the dose. They also needed to carefully monitor their patients for adverse reactions or toxicity. Nurses had always observed children for side effects of serum, so monitoring them was not a new demand. What was new was the level of detail and expertise required to perform that monitoring and the growing complexity of those assessments. In addition to administering the medications, for example, the sulfonamides required that nurses track intake and output much more precisely than they had in the past, in order to assess for renal toxicity and other adverse reactions from the drugs. In infants, for example, assessing fluid output posed practical challenges of making this assessment in a diapered child. In toddlers and older children, it meant cajoling them to use a bedpan, measuring the contents, and possibly sending a sample onto the laboratory. As the scope of research at Sydenham expanded and the use of the lab grew 50% actually between 1939 and 1941, nurses became increasingly responsible for growing amounts of data collection. And you can see this in the new generations of flow sheets and medication records that document the greater precision, complexity, and voluminous amounts of nursing care delivered relative to the past. Next slide, please. In addition, nurses needed to monitor children's children's intravenous fluid, increasingly now delivered in a continuous drip form instead of the physician-administered subcutaneous bolus that occurred in an earlier era. So this meant that nurses needed to figure out how, for example, to anchor an IV in a baby or toddler, adapt tubing to make sure too much fluid was not administered, and then record the infusion hourly to make sure the child didn't get too much or too little. All of these new routines played a major role in completing the transformation of the children's wards at Sydenham and elsewhere, from home-like environment to a medicalized, more technologically driven space. The sulfa drugs also forged a need for more nurses that quickly eliminated any cost saving from the sulfonamides over serum. By the late 1930s, correspondence among hospital administrators reflects a growing concern that there were inadequate numbers to perform the complicated nursing care children now needed. One emergency memo in 1940 underlines the word dire 3 times, situation in terms of nurse staffing. Unfortunately, for someone who's interested in the history of children's health, one thing I can't see in the records is a sense of how these drugs may have changed the experience of sick children or their parents at Sydenham. I think it's reasonable to assume that parents rejoiced at improving survival rates, and the youngsters themselves appreciated getting better and the reduced permanent disability the sulfonamides afforded over serum. And they also most likely preferred getting the drug orally as opposed to an injection, even if they didn't like the taste. But I can't really do more than that in terms of thinking about what the children and parents thought. Next slide, please. Sydenham's successes naturally found its way into the press with fawning articles. Here's just one example from 1939. Whereas no children with post-measles bacterial pneumonia survived at Sydenham before the mid-1930s, after the introduction of sulfapyridine, almost half did. An astonishing recovery rate, the Baltimore Sun trumpeted in the article. Sydenham checks 2 scourges, meaning measles and the post-measles pneumonia. Issues surrounding the sulfonamides pointed up the need for new drug legislation in the United States. There was a new drug law enacted in 1938 that provided new mandates for drug safety. It was passed in the wake of a sulfa-related disaster involving the product elixir sulfonamide. The crisis occurred because of an additive added to the drug to sweeten its taste for the pediatric patient ended up being poisonous. It was actually diethylene glycol. Dozens of people, including a number of children, died. It's beyond the scope of this paper to discuss the event in depth, but it led to the largest revision in drug regulation in the United States up until that point. I talk about it with regard to children in my book. Daniel Carpenter, in his book on the history of the FDA, talks about it extensively. So if you're interested in it, I suggest you check that out. I spent a lot of time, as I said, studying the bill as it related to children and discussions around pediatricians and pediatric organizations and nurses with regard to the care of the pediatric patient. I found out one thing that was interesting. The original bill that was introduced in 1934, before the sulfonamides, did address in the language drug safety for youngsters specifically, but the final approved bill in 1938 did not include any mention of children at all for reasons that are unclear. I have a couple of hypotheses. I think most likely reformers and policymakers believed that the broad language regarding safety would include children, so they didn't feel a need to mention them by name. It may also not have seemed necessary because although the elixir sulfonamide crisis involved a number of children, the problem was the additive, not the drug. And the event didn't really spotlight the unique challenges involved in determining pediatric dosing either. Moreover, when the law was finalized, the sulfonamides had only been in use for slightly over 2 years. The ways they, and soon penicillin, would change pediatric practice and drug therapy were still unfolding. Next slide, please. And this is a slide. The American Medical Association had a periodical for members of the lay public called Hygeia. And here's something in 1940 where it is an attempt to educate the American public at just the ways that the sulfonamides were going to change American childhood. But in order for a drug to be considered safe for children, sulfonamide or any drug, and for the drug to achieve the full benefit and for children to achieve the full benefit under the 1938 law, youngsters needed to receive the right amount. Too much was constituted a poison, and too little might not work. And unfortunately, the legislation did little to advance regulatory procedures specific to the issue for children. If a company was lucky, they might have some pediatric data to submit to the FDA, but most of the data they had drew from adults. Very quickly in pediatric healthcare, the norm became post-market trial and error administration of drugs approved by the FDA in children using adults will be followed by publication in the pediatric medical literature to help set dosage norms, identify concerns, and safety issues. I'm often asked about how, if at all, consent for the experimentation and treatment with the sulfonamides and later penicillin were handled at Sydenham. At some point, as best I can tell, in the early 1930s, upon admission, parents signed a consent form that would give that gave doctors blanket consent to provide the care and treatment that physicians thought necessary and appropriate. As Susan Lederer and others have noted, this was not unusual practice for the time. Physicians largely policed one another in practice and in the medical literature. In terms of nursing in this era, while early ethical codes certainly articulated a duty to patient, they stressed the need to follow rules set by nursing and medical superiors. The situation's further complicated in nursing because often in institutions, those providing nursing care were students, so they of course possessed less agency and knowledge than trained nurses. And in fact, it wasn't until 1943 that Sydenham became affiliated with the prestigious Johns Hopkins Hospital Nursing School, because until then, its leaders considered the staffing and the nursing care provided at Sydenham so weak that they didn't want to send nursing students there. The benefit and risk calculus of drug testing for children also changed over time, further clouding issues of risk and protection. In the late 1930s and early 1940s, despite a paucity of information about pediatric and sulfonamide dosing and drug metabolism, one can argue that it made sense to expose critically ill children with often fatal bacterial infections to the drugs. But clinical decision-making became more complicated in the wake of newer generations of sulfonamides, the subsequent availability of penicillin, which becomes available at Sydenham in 1943, and post-war antibiotics and the broad-spectrum antibiotics in the post-war era. Once a drug that works fairly well is available, when is it worth trying a newer, potentially better drug about which much less is known? And who decides that? And one thing I'll mention here about the introduction of penicillin at Sydenham is that the care template developed for, and the nursing and medical care processes developed for the sulfonamides made it easier for penicillin to be rapidly introduced into practice, as Jack Lesh and others who've written about the sulfonamides have observed. Complicating scientific issues regarding testing and use, issues around dosing and metabolism relative to the sulfonamides made it increasingly clear to pediatricians in the early 1940s that there were numerous subpopulations within pediatrics and that the metabolic and physiological differences between premature babies and newborns and toddlers and older children had great clinical significance in terms of drug metabolism and what we today call pharmacokinetics. As a result, they began to argue that the information gained from research undertaken from adult patients not only couldn't be extrapolated to the pediatric population, testing was needed in each of these subpopulations, making an already complicated situation even more so. This new knowledge, as well as the growing complexity in terms of the medical and nursing care needs of children receiving the drugs, also created a potent argument for the need to educate all nursing and medical students about pediatrics. And their recommendations for a standardized curriculum become published in both the medical and nursing literature in this era. And this is significant because until then, and until the post-war era, not all medical or nursing schools required a pediatric education. The sulfonamides and then subsequently penicillin would also synergize pediatric knowledge in other ways because they helped make other conditions survivable, which would permit more research and trial error into other treatments. Children with heart disease, for example, who received surgery were more likely to survive post-operative infections. And C. Everett Koop talks a little bit about this in his autobiography. Conditions in which children had rarely survived childhood, such as cystic fibrosis, could recover from their frequent lung infections and live longer. So it had a major secondary effect in terms of pediatric morbidity and mortality. Along with better nutrition and other public health measures, immunizations, the sulfonamide, and antibiotics helped make childhood death increasingly rare by the post-war era. Next slide, please. And it soon allowed the luxury of a focus beyond that of physical health. And this is from the 1950 White House Conference on Children and Youth. These conferences were held about every 10 years, beginning in 1909. And this is the first one that focuses on issues beyond that of physical health. Now, there will also the field of developmental psychology is growing. There's also the growth of well child care in this era. This isn't the only factor, but I do think the fact that diseases that had once been almost universally fatal could now be treated with a pill as an outpatient certainly allowed people to move forward to thinking about other issues in children. By the 1950s, the pediatric antibiotic market was big business. FDA records in the National Archives show that by 1953 and 1954, how important a pediatric formulation had become to a full product line. And the detail men or sales agents in the field are actually writing pleading letters to their corporate headquarters to have them, and basically saying they're leaving dollars on the table because they don't have them. And this is, of course, in the context of large numbers of children being born in this era. The baby boom probably had something to do with that market demand as well. There's also a call for pediatric formulations in over-the-counter drugs as well. And in my book, I talk about children's aspirin. But as new drugs flooded the market, the FDA, scientists, pediatricians, pediatric nurses continue to grapple with how to apply adult data to pediatric patients without a mandate for industry to gather data, submit it to the FDA, and with no consensus on how to pay for the additional testing, development, and by the 1960s and 1970s, worries about the ethical concerns of testing in children. And I grapple with the policy implications throughout the rest of my book. All of those challenges grew even worse after the next big revision in drug laws in the early 1960s in the wake of thalidomide, when new rules regarding the importance of drugs being effective and based on adequate and well-controlled trials and language regarding consent to participate in experimentation become codified into federal law. And they're not truly addressed in children until we get those 2002 laws that I began with. The Best Pharmaceuticals for Children Act, which provided financial incentives for drug companies to test drugs that were already on the market, and the Pediatric Research Equity Act, which demanded pediatric data for drugs that might be used in the pediatric population. Next slide, please. But those issues about risk and that calculus of risk and protection haven't gone away. This is from 2018, JAMA Pediatrics continues to talk about what a tricky balancing act it is. There was an article just published in JAMA Pediatrics that noted that of the 275 COVID trials that were registered between February and April on clinicaltrials.gov, only 30 were open to children under the ages of 18 years. But all of this, that was in the future. What you can see at this turning point in the 1930s, 1940s, and in the patient records is just how miraculous the sulfonamides seemed to clinicians in transforming what had been fatal diseases into ones not only treatable, but curable with a pill as an outpatient. By so doing, they helped change American childhood, parenting, nursing and medical care, and indeed societal expectations for children's health and well-being going forward, and the entire template in which we thought about children in the United States. Thank you very much, and I'm happy to take your questions at this point. If I could just have the last slide that has my acknowledgements, please.
Thank you, Dr. Connolly, very much. The first question we have is the one that you posed about the Sydenham records that are held by the National Library of Medicine. And with thanks to my colleagues in the History of Medicine Division, particularly Rebecca Warlow and John Reese, so we have an answer for you.
Oh, great.
We acquired those records in the fall of 1968 from Baltimore City hospitals, particularly a gentleman named John DeHoff. And we believe, based on what we know remotely, because we can't access the actual files on site because we're maximum teleworking along with everybody else, we think the donation was made very quickly because the hospital storage facility was at that time being torn down. There is a donor file that we'll look at when we are back on site. The donor file mentions the sampling method, and we think that the main factor in deciding to sample was simply the very large size, the volume of the files that were slated for the trash because of the hospital being torn down. So it could have been an arbitrary selection, but that's what we know at this point in time, and we can investigate more when we're back on site and have access to our files.
Well, thank you. I said I always kind of wondered about that, but never thought to email when you were actually on site. So thank you very much for illuminating us. Thanks, John. Thank Dr.
Absolutely. Absolutely. With all credit. Absolutely. We have another question that's come in, and it is that as nurses had the most direct and continuous observation of pediatric patients during the experimentation with sulfa drugs and dosing, did their relationship with physicians change? Did they find themselves advising doctors about dosing and timing, et cetera, based on their empirical experience?
So that's a great question, and I thank the person who asked it. From the Sydenham records, I can't answer that question based on the Sydenham records, but based on other clinical records, I have seen that yes, they began to develop more of a partnership than they otherwise had. I think each group perhaps realized they needed the others. In terms of the adult patient, my colleague at Penn, Julie Fairman, has written about this extensively in her book on critical care nursing, about the ways in which the growing need for the critical care, the adult critical care patient, really changed the working relationship for with regard to nurses and physicians. And I have seen that in other places in the nursing and medical literature, and from doing oral histories of older pediatric nurses, pediatric nurses and pediatricians older than me. Let me say that. So great question. Thank you.
Thank you. Another question it pertains to the image from Hygeia that you showed. This person is curious to know how prevalent were these advertisements, and did you, through your research, see them change over time in any way?
So that's a great question. So the advertisements for the drugs themselves, I do talk about in a different chapter, and but I'm happy to answer that question here. So for actual drug, for over-the-counter drugs, the people who made them, they were able to advertise to parents, to the public directly, right? In Parents Magazine, in newspapers, anywhere they wanted. They were policed if they weren't truthful, but they had a lot of they had a lot of flexibility in terms of the way in which they marketed their products. For the prescription drugs, which the sulfonamides, penicillin, antibiotics were, the drug makers could advertise generally that they made products that benefited people, but they couldn't say, as they can now, talk to your doctor about sulfapyridine or amoxicillin And so what you see in Parents Magazine through the 1950s and 1960s are the large drug houses taking out advertisements that are usually, although they're all white families, they are heavily gendered. It's usually mothers sitting around drinking coffee while girls play with dolls and boys play with trucks or some other stereotypic boy toy. And the one mother will say to the other how lucky they are to be living in this time when there are so many drugs that that can benefit children and make children healthy. So they weren't, like I said, they weren't able to say if your child has strep throat, then you should ask your physician for X or Y. In terms of advertising, but that's what I saw in the pediatric literature. Now, it's in many of the medical journals, the ones that were saved and are available online. Unfortunately, so often they have the articles, but what would be considered extraneous, the advertisements weren't saved, and so as they became available electronically, a number of libraries got rid of the old hard copies that you used to be able to go to the basement of the library or request from off-site. And so for a lot of those old journals, we can't see those advertisements anymore, but certainly they were directly advertising to physicians, not in nursing journals during that era because nurses couldn't prescribe, but where nurses are being used in lay literature and in medical journals as how nurses add to sanitation and sort of a professional atmosphere of healthcare.
Thank you. Thank you. We have two other questions that have come in through the videocast link. The first one is, how did the results of the sulfonamide treatment compare with those in England? Were there factors particular to the American context?
So I don't believe. I mean, I don't believe so. So with the two Hopkins, Karen Long, who was a famous pharmacologist, he had gone to a research conference in England, and so he had been at one of the early conferences where the sulfonamides were presented, and he brought that back to Hopkins, and you can see some of that there's materials in the Chesney archives at Hopkins that talks about that, and then also some of his papers, which I believe his papers are at NLM. I can't quite remember where I saw them, but I did look at his papers. It may have been at the Countway. I can't quite remember where I found those materials. But and certainly in Great Britain, they were doing testing on similar types of testing. So I did, aside from the fact that in Great Britain, the articles that I remember seeing about children in those trials, they're not breaking down the children by race or ethnicity, because I think they had a more homogeneous sample to draw from. That was the biggest difference I remember seeing, is that they did not break that down in their results the way the Americans did.
Thank you. Another question we have, was there any information about the cost of sulfonamide therapy and whether patients or their families could afford this treatment?
So again, great question. So first of all, the sulfonamides were cheap. The pharmacologically active ingredient was off patent, and so the money to be made was in the formulation, which was why so many people were coming up with all these different formulations of, for example, what became elixir sulfonamide, and racing it to market, because that was where the money was to be made. And so first of all, the children at Sydenham were staying in the hospital for most of the time that they were receiving the drugs, and the drugs themselves were remarkably inexpensive, even in that era, because so no, I didn't see any discussion, and I think it was because they considered that the cost wasn't that big an issue. If a family couldn't afford it, since they were already being treated at a public hospital, they could be seen at one of the follow-up public clinics available, either at the Harriet Lane home or through Sydenham Hospital.
Thank you. We have time for one more question. You mentioned during your presentation conducting oral histories. Could you share a bit of what you found particularly on the psychological emotional experiences?
Oh, thanks for asking that question. So I did interview a number of pediatricians who had been involved with the American Academy of Pediatrics Committee on Drugs. That was the place where I could really find, aside from published articles, that was sort of the record of pediatricians' efforts formal efforts to be able to address this topic. And so I found a number of physicians who'd been involved with that group. And so they talk about, two of the 6 or 7 that I did just talk about, they still remember exactly where they were, the lighting, what it smelled like, what it felt like when a child who the other 10 patients before with this diagnosis had died, and this child seemingly completely got better. I spoke to one nurse who said that she went on maternity leave, and before she went on maternity, she was not a nurse at Sydenham, but she'd been a nurse in Newark, New Jersey. She went on maternity leave, and before that, children with infectious diseases stayed at the hospital for many months, having their wounds drained, getting serum therapy. When she came back from maternity leave, less than 2 years later, that it was completely changed. All the patients were patients being admitted with chronic illnesses and for congenital surgeries, and all the infected children were now being treated as outpatients. And she said that seemed to happen, it felt like overnight to her.
Thank you. I'm sure the individual asking that question appreciates that very much. Thank you. One more question we have. How did physicians decide which diseases the sulfa drugs could treat?
Great question, and I wondered that myself, and this is something, again, you can see not in the clinical record, but in the monthly reports of Sydenham physicians and in the annual reports. They're trying them as they come on the market until 1941, when quickly it becomes whatever the infection that is most common for soldiers in the field are experiencing. That is going to become the infection that's going to become the bacteria that they're focused on, and in the sulfa drug that they think is going to be matched most carefully to that.
Thank you. As we approach our hour, several other questions have come in. Would you indulge us for a couple more minutes? Is that okay?
Me, are you talking to me? Of course, yes, yeah, absolutely.
Sure. Okay, great. The wonders of technology. Was there widespread resistance to the new sulfa drugs among parents and families, similar to what we see now regarding vaccinations, or were most parents anxious to have their children receive these medications? And if it was the latter, that they were anxious to have their children receive the medications, was that likely based on successful advertising in any way of those drugs?
So that great question. But I do think the parents were. I see no evidence that parents weren't happy. In fact, in another chapter, in another part of my book, I talk about how upset pediatricians are, and pediatricians mount a campaign because they feel as though the sulfonamides and then penicillin have really changed the balance of power between the pediatrician and the mother, because they are very affronted with what they say are demanding mothers who come into the practice and want a particular, not just want an antibiotic, but they want a particular antibiotic that either worked on them or worked on another child or their neighbor's child. And so no, I think that I don't see any evidence that they were anything other than thrilled. And I think it's because these diseases were so well known for whooping cough, diphtheria, right, for taking the lives of so many children, and that was in the living memory of parents and grandparents, that the luxury that we would have in subsequent generations, it would just disappear. I mean, I often tell my nursing students that I'm of the last. I've never seen a clinical case of measles, but I saw lots of chicken pox. But the students who trained with me and within the last 20 years aren't going to have seen lots and lots of chicken pox since we had a vaccine. And so since we now have a vaccine, and so I do think that in that era, the high morbidity and mortality rates from those diseases were so fresh in the minds of the American public that they were just uncritically thrilled.
Thank you. Well, Dr. Connolly, thank you very much for an outstanding presentation this afternoon. We're grateful. All my colleagues and I at the National Library of Medicine, thank you for your time and your preparation and for coming to do your research at our institution and other institutions like the many that you've named. And we look forward to keeping in touch. And thank you very much.
Thank you. It's my honor. Thank you.
Thanks, Cynthia.
It's my honor to be here, and I look forward to actually being in that reading room again.
Great. We look forward to hosting you and everyone.
Thanks
Thank
so
you.
much.
Thank you.
Good afternoon, everybody. Thank you.